So, good afternoon, everybody. Of course, my name is Dr. Faisal Alsaqabi. I'm a consultant rheumatologist at Kuwait. In Kuwait, actually, now we have up to 16 rheumatologists, consultant rheumatologists, 4 adult, 4 pediatrics consultant rheumatologists, and 12 adult rheumatologists. All of us have been trained in North America, in Canada or USA or both. So for this reason, number one, I want to thank International Hospital of Bahrain to ask me to come today and give our experience in the treatment of advanced treatment of patients with rheumatoid arthritis. And so I'm not going to talk about biological in general. I'm going to talk only about interleukin-6 inhibitors, or Actemra. So as we understand since morning until now that, and all of us maybe they will agree that arthritis or rheumatism is the leading cause of chronic disability. And the prevalence, of course, of rheumatoid arthritis is different from country to country. And it is more common in female than male, but in general it's around 0.8%. The way how to diagnose rheumatoid arthritis, I can say it is only clinical diagnosis. We don't depend too much on the investigation, but if it is, for example, you have the acute phase reacting, it will help you. You have the antibody positive, it will help you. But it is merely a clinical. So when you are looking to the patient, for this reason, we are looking to the patient. We are not looking only to his joint, how he functions. We are looking for the activity of his disease. And this brings us to the what we call treat to target. For some reason, we don't know what's going on. But patient with rheumatoid arthritis, at one day, at one time, he will wake up and his dendritic cell or antigen-presenting cells, she will saw something abnormal in his joint. We don't know this what. It could be proteins or anything. We don't know exactly. And this will lead the cascade to the activation of the chronic inflammatory cells, which is the T lymphocyte, B lymphocyte, and of course the activation of macrophage, and the production of a huge amount of cytokines, especially the TNF, and then the interleukin-6. Why they go advanced in interleukin-6 inhibitor? They go there because we think that interleukin-6 play the central role. So it is the master, it is the head of the neck, head of the snake. So as I mentioned, I'm not going to talk about anti-TNF. I'm going to talk only the new era in the treatment of rheumatoid arthritis, which is the Actemra, or Actemra, and interleukin-6 inhibitors. Interleukin-6 inhibitor, I came here today not to talk about interleukin-6 inhibitor, how effective, how safe, because all this had been established already by 5 different large clinical trials. And Actemra showed that it is superior, not only as it can be superior as a monotherapy compared with methotrexate, or combination of DMARD, including methotrexate, or even patient failure for anti-TNF. As I mentioned, we have up to 16 rheumatologists in Kuwait, and we have around 2,000 patients on anti-TNF, so we are lucky in Kuwait, because it is free of charge as rheumatologists, and the patients are lucky also because they can get very easily anti-TNF. So for a population of 1.2 million only Kuwaiti, 2,000, it's a huge number of patients on anti-TNF, and we have on Actemra around almost 280 patients on Actemra interleukin-6 inhibitor. So this will be a huge number of patients on anti-TNF. Why we go to this extreme? Because we start to think that the only evidence to stop progression of disease is biologic. So there is no rules, there is no big rules. I mean, there is no big rules for the traditional DMARD. I'm going to talk only, not all about all the patients, I'm going to talk only about my patient. The number increase, I have now up to 45 patients on Actemra. But when I prepared the slide, it was only 42 patients. The patient who have been diagnosed with rheumatoid arthritis, not necessary to be typical for ACR criteria for diagnosis of rheumatoid arthritis. I'm talking here also about a patient who have been tried different things. And before, we don't have anything for them, any options. Either to go backward, start the patient again on gold therapy, or cyclosporine, or to go forward more steps and start patient at Actimra. This type of patient, they try different DMARD. This type of patient, they try different DMARD combinations, monotherapy. They want to anti-TNF, and they still have active disease. As we understand in the morning from Dr. Muhammad, that we have to target remissions or at least low disease activity. So most of the patients, they have bad prognostic factors, and we have the DAS28 for them, it was quite high, even on DMARD. A few patients, they are taking small dose of steroid, which is also very bad. Still now in 2011, we have patient with rheumatoid arthritis and he's on steroid. So this old fashion has been changed with introduction of anti-TNF. Large number of patients still are taking anti-inflammatory, try to control their symptoms. And they still have high CRP and ESR. The way I follow up my patient in my clinic in 5 different ways. And usually, it will not take more than 5 minutes to 6 minutes to complete all this. I have patient self-assessment of disease activity. That means what the patient think about himself. This is very important. What the patient think about himself. And then I have the DAS28. DAS28 exactly like a scale. If you want to know your weight, you have to stand on the scale. And if you want to know the disease activity in patient with rheumatoid arthritis, you have to do for him DAS28. For a patient with started on Actimra, we start with patient that feeling they are in very bad condition. And this only the need for the 42 patient, they think themselves it's almost around, they give themselves around 90% disease activity. When the patient had been started on Actimra, within 3 months, there is significant reductions, only within 3 months, significant reductions in the patient, what he feels about himself, which is quite very important, that what the patient feels about himself. Around more than 30% improvement within 3 months. This improvement is maintained over 1 year, because until now I follow the patient for 1 year and show that. And this can bring us back to the rule of early introduction of biological in the patient. This type of patient, they don't have, like if you compare the patient self-assessment questionnaire with the HAC, you found that the reduction, it is not like the slide before, because here we are waiting a little bit for the patient on different DMARD, and then we go to the biological. So this can give indirect indication that if we go straightforward, if you think that the patient he has bad prognostic factors, or the patient is not responding within 6 months, we go direct to biological, maybe we can reduce their HAC. Physician global assessment, also my assessment for them was that they have significant improvement, and the most important, their ESR and CRP drop very dramatically within around most of the patients within 2 weeks within 2 weeks after the first infusions, but most of the patients within 6 months they have normal ESR and CRP. So that means this is very important slide to concentrate and to stand here only 1 minute about what happened to this type of patient, which is many years ago, let's say more than 15 years ago. We don't have for them any options. The patient will destroy his joint. At the end, he will go to rheumatologist. Now, with the introduction of a new biological like interleukin-6 inhibitor, we can save a huge number of patients from the knife of the surgeons and destruction of his joint. The most serious thing that we are afraid usually from the side effect of all biological, but here especially for anti-TNF, especially for interleukin-6 inhibitor, which is the serious infections, especially for opportunistic infections, cardiovascular events, malignancy, gastrointestinal event, and infusion reactions. About the infections, the rate of infection for patients who are receiving tacruzumab or the Actemra, raw Actemra, it will be almost same as the rate of infection in other biological, or maybe it will be even less. And the rate of infection, it will not depend on how long the patient on Medicaid, on the treatment, for how long you are keeping the patient, because we have strong evidence, even after 60 months, still the rate is almost same. And the average acceptable rate, it is almost between 4 to 5% of serious infections. In our cohort, still we are lucky because still I have only one patient. All of us from the first slide, we understand that, as I mentioned, rheumatoid arthritis is not only a joint problem, and even it is a systemic disease. So patients with active rheumatoid arthritis not treated, they can develop coronary artery disease. And even it is the #1 cause of death for patients with rheumatoid arthritis, which is the cardiovascular disease. It could be the role of IL-6 and CRB. And of course, it could be the reason for atherosclerosis. Could be the patient can affect his heart, so he can get myocardial infarction or even stroke. But the rate of cardiovascular event do not increase over the time with prolonged exposure to tacruzumab, and it is as compared at other anti-TNF. And even there is a unique and durable CRB normalization, as I mentioned before. Within 2 weeks after the first infusion, CRB will drop back to normal. And that can impact the cardiac risk in a patient population that is being further explored. Malignancy, we understand also patients with rheumatoid arthritis are at a risk. Patients with untreated rheumatoid arthritis, they are at a risk to get, especially hematological malignancy. And patients who are receiving non-biological DMARD also at a risk to get malignancy. Patients who are receiving anti-TNF, they are also at a risk to get malignancy, especially hematological malignancy, and it is very rare for solid tumors. Of course, the rule it will apply also for Actemra, but the most important that the rate of malignancy, it is not higher than other anti-TNF, and still I don't have any signals of malignancy in my cohort of patients. Of course, it is IV medication, so don't expect it will be without any reactions. But when we compare, like with other medication, for example, with infliximab or other anti-TNF or with CD20 infusions, for patients who are receiving Actemra, the rate is very, very low. For this reason, no need to start the patient on any pre-medications like antihistamine or even giving the patient any steroid. Infusion reaction, it happened only once with us for one of the female patients with the second infusion, and she had been treated with stopping infusions, and even with patient received some steroid for 1 week with antihistamine, resolved completely. The lipid. While you're patient on Actemra, you have to keep your eye every at least 2 months, 3 months on his lipid profile. Because most of the patient, or a few number of, most of the patient, they can develop hyperlipidemia. And usually the way we treat that, especially for LDL, and usually the way we treat that, it's by the regular way we treat patients with hyperlipidemia. That means it depends on the risk and how high his lipid profile, on his risk of cardiovascular disease. So lipid monitoring, assessment of lipid parameters should be performed every 8 weeks following initiation of tacruzumab, Actemra, and the patient should be managed according to the clinical guidelines and his cardiovascular risk factors. Liver function test, it can be during infusion. Patient with receiving Actemra, their ALT, AST, it can go up, but this is also not a red flag to stop the medications. unless the patient they have a huge increase in their liver function test, more than 5 upper limit of normal. But if it is between 3 to 5, same thing, you can reduce the dose. So what I can conclude that rheumatoid arthritis is a chronic systemic autoimmune inflammatory disease associated with extra-articular manifestation. You have to keep in your mind the extra-articular manifestation. It is a systemic disease. I think that with the introduction of all this biological now for the last 15 years, we're supposed to have less patients, especially with the new rheumatologists, this patient referred to a surgeon to start to have any type of replacement, joint replacement. The side effect of Actimel or tocilizumab, it's as the other entity NF, and tocilizumab has a well-defined and meaningful safety profile that has been similar to other biological as we mentioned. So this was only for a real type of patient, not patient including on clinical trials. I don't know if somebody have any question.
I think, Biologics has opened an era for us for early intervention, which is very important. And this way we can minimize the number of patients who will go on steroids and the number of patients who will have complications. But sometimes it has its limitations because usually what's desirable is not achievable. For example, if a patient comes late to you, whatever you give to him, it's too late. So I think early intervention, but it comes to a stage where the economic factor plays a very important role. I think you are very lucky in Kuwait that you visit with the patient, but our self-paid patients, if they don't get better, they make our life hell because they have paid the money, and insurance is not very strong
like in Gulf, in Gulf in general,
yeah.
Like especially like in Kuwait, because I'm working in Kuwait, patients within 6 months from diagnosis can go to biologic.
So you can give it to methotrexate naive patients, so just as first line? Or
no, we'll try methotrexate.
You try methotrexate, so it's not methotrexate.
And even sometimes I start the patient, we have we have evidence, the patient they have bad prognostic signs. You know that this patient is not going to behave like, he will go like to severe disease activity. So in the beginning, I can start the patient on biological straightforward, and we have evidence for this.
Yes.
It have been tried like with.
Yes, in the state they have a lot of evidence on.
For this reason, you will find the era of surgery it will be less and less for patients with rheumatoid arthritis. Still, of course, we cannot treat everything. We cannot fix everything. Some patients maybe they need a surgeon help.
Now, if a patient wants to get pregnant.
Okay, thank you. I think Dr. Hamouda has a question, please, okay?
The recommendation for doing X-ray for rheumatoid arthritis is once per year. Did you find any benefit of doing more frequent X-ray every 3 months?
Yes, because usually when I start a new medication like Actimel, I want close follow-up for the patient, only to see if there is any change, and any significant change. Because the medication is very quite expensive medications. Like for example, I have one patient, I stopped her medications. She never had any improvement in her DAS 28, and she's still progressing within like 6 to 12 months. So no need to wait more for the patient and stop biological because she's not doing anything. I know it is every 6 or 12 months you need to do for the X-ray, but for us, because it is a new medication, I have to keep my close follow-up for the patient. For this is I do every 3 months, the X-ray handling.
I just put as a total and actual contribution per million. For the 6 years, Kuwait was the highest, and I think that should be actually recognized. And also I look for something else which is a doubling the time every year. And the highest in doubling the time is Qatar and Sultan of Oman. But until now, Kuwait, by million population per year, is the highest, and it seems that from your work, you are still working on it, and wish you and your country all the possible progress.
Thank you.